You are listening to the Nurse Documentation Podcast, brought to you by Nightingale.
Nurse documentation. Protect the care you gave. Protect the license you hold. With every note you save. Nightingale, where good care is safe.
Welcome back to The Deep Dive. Today we're taking on a subject that is, frankly, critical for anyone in pediatric nursing. We're going to be pulling material directly from the Nurse Standard Pediatric Fever and Medication Documentation Playbook.
That's right. And if you're a licensed nurse in a pediatric setting, whether that's in a hospital on a busy med-surg floor or, in a home health case or even a specialty clinic, what we're talking about today isn't just compliance paperwork.
No, this is much bigger than that.
It really is. This is about your professional accountability. So our mission really is to translate these pretty rigorous principles into the absolute must-have standards you need for your own license protection. We want every note you write to be bulletproof.
And for every entry to serve as, legal evidence if it ever comes to that.
Exactly. Indisputable legal evidence.
So we're basically providing a framework, a structured system that's designed to cut through the chaos that comes with taking care of acutely ill kids.
It's about replacing that feeling of improvising under pressure with a standard, a clear and repeatable process.
Because calm really does come from clarity, especially when the stakes are so incredibly high.
And the urgency here, it really can't be overstated. Pediatric charts are just inherently high-risk environments.
Why is that? What makes them so different from, say, an adult chart?
Well, it's really three factors that come together to create these extremely small margins for error. First, a child's weight changes so fast.
So a weight from last week might already be out of date?
For an infant, absolutely. A weight from last week could be stale this week.
Yeah.
And your dosing calculation, which is, precise down to the milligram per kilogram, it has to reflect that change.
Okay, that makes sense. What's the second factor?
The second is just the child size. There's a very narrow therapeutic window. So dosing errors, even tiny ones, their effect is magnified exponentially.
And the third?
The third is just the critical importance of spotting deterioration early. Kids are amazing compensators. They can look fine until they're suddenly not. And that subtle shift, maybe in their temperature trend or just their responsiveness, that's often only visible if your documentation has been absolutely vigilant.
I think so many nurses, especially, when you're short-staffed, when you're under pressure, you fall back on habit. And that's really where the vulnerability starts, isn't it?
It is.
So what are those common sort of quiet ways nurses get exposed to risk without even realizing there's a gap in their charting?
It almost always boils down to relying on memory instead of immediate verified logging. Let's talk about the four common ways we see this in chart reviews. The first one is just relying on memory.
Okay, so you take a temp, the parent asks the question, the phone rings.
Exactly. You get distracted by a crying child or a call, and you fully intend to chart it later. But if you miss that exact time by, say, 15 minutes, you've just broken the fidelity of the entire trend.
That sounds so minor, but I guess in a legal timeline, 15 minutes could be the difference between proactive management and a delayed reaction.
It absolutely could be. The second big exposure point is accepting an unverified single reading, a single high temp, let's say 103.5. It might just be a fluke.
Like an equipment error.
Could be the equipment, could be bad placement, could even be that the kid was just bundled in a warm blanket. If you chart that single high number as fact without, running a verification protocol, you risk intervening too fast or alarming the whole team based on bad data. Auditors look for that verification step.
And that gets right into the snapshot problem versus the trend problem. You're charting one data point, not the trajectory.
Precisely. The third area, and this is probably the leading cause of dosing errors, is using stale or guessed weights. If an order says 10 milligrams per kilogram of acetaminophen and you use a weight from 3 months ago, you're not dosing. You're guessing.
You have to link the dose to the current weight.
The current recorded weight. And the fourth major exposure, and this one trips up even really experienced nurses, is misinterpreting varied medication concentrations. You might be used to the standard Tylenol you have in the hospital.
But then in home care, you might get a different bottle.
You might get an older formulation or a compounded product. And if you don't document that, you verified that specific concentration. Is it 160 milligrams per 5 millimol? Or is it, say, the super concentrated 80 milligrams per 0.8 millimol drops? If you don't document that check, you can make a huge...
It really sounds like the goal here has to be a mental shift. Documentation isn't a chore. It's your professional defense mechanism. It's your armor.
That's the exact reframing we push for. We want every nurse to adopt a standard system. We call it the Standardize, Simplify, Verify, and Document framework.
Go break that down.
Standardize your measurements in context. Simplify your workflow with tools like checklists. Verify every single number, every calculation, every site, and then document immediately and thoroughly. It's that repeatable process that creates calm. It proves your competence, and it shows vigilance when that chart gets reviewed, whether it's by a peer, an auditor, or an attorney.
All right, let's unpack that first piece, standardization. We're moving into the real nitty-gritty now, the pediatric fever documentation standards. So a chart gets open, maybe after an adverse event. What are those non-negotiable things that have to be there every single time? What's the first thing a reviewer is looking for?
The very first thing an auditor or a legal investigator looks for is consistency and context. If your data isn't consistent, it's immediately flagged. It's seen as unreliable because it's not comparable.
So to be reliable, what needs to be standardized?
3 things every time. The exact time, the exact measurement site, and, if you can, the device you used.
Why is the site so critical? I mean, a temp is a temp, right? If I get 101.5, why does it matter if it was temporal or axillary?
Oh, it matters hugely because you're not comparing apples to apples. Let's say you chart a temporal reading of 101.5 at 9 a.m. Then at 10 a.m., you chart an axillary reading of 100.8.
The temperature went down.
Did it? Or did you just measure differently? Temporal and oral temps, they track closer to the core body temperature. Axillary readings are generally a bit lower, and they're much more affected by the environment.
So by mixing the sites?
You create non-comparable data. You've compromised the trend, which is, it's the heart of your clinical assessment. So standardization means if you start with axillary, you stick with axillary. And if you have to change the site, you must chart the reason why.
That makes perfect sense. You're taking the noise out of the signal. Now, the playbook says context is king. A number by itself is meaningless. How do we capture that context efficiently when we're, swamped?
You're right. The number is totally useless on its own. So for every single fever reading, you have to document these little context tags. These are the things that explain why the temperature is what it is.
Like what? What are the critical ones?
The time since the last antipyretic was given, the child's hydration status, are they taking fluids, are their lips dry, their activity level, this is a big one. Were they just screaming for 10 minutes or wrapped in a warm blanket? Or are they totally lethargic? And then, of course, any co-symptoms. Irritability, shivering, restlessness.
Okay, let's use an example. A child's temp is 102.1. You just took it right after they had a 10-minute crying jag because they wanted a toy. How does that note look?
The note has to be specific, not just temp 102.1. It needs to be temp 102.1 axillary. Child crying intensely for 10 minutes prior to measurement. Settled now, resting in bed, alert.
Ah, that last word. Alert. That's key, isn't it?
It's everything. It immediately tells the next person reading the chart that, yes, the temperature is high, but it is not at this moment associated with neurological compromise.
Right.
It provides that critical context that protects you from causing unnecessary alarm or escalating when it's not needed.
Okay, now let's talk about the safety net for bad data. The 3-read rule. This seems like a direct defense against those equipment flukes we were talking about.
It's the gold standard. The 3-read rule is your documented defense against a false outlier. If you get a reading that's surprising or really concerning, let's say you get a 103.8, and that's just way out of character for this patient, the procedure is very specific. You do not just log that number.
What's the first step then?
First, you wait. Just 1 to 2 minutes. Let the device cool. Let the child settle. Reposition the probe. Make sure they're calm. And remeasure at the exact same site.
And what if it's different?
Let's say the second reading comes back at 102.5. That's a huge difference, over a degree. So now you know the first reading was probably faulty, but you still need to know which one is the right one.
So you don't just average them or something?
No, absolutely not. If that second reading differs significantly, and the standard is about more than ½ degree Celsius or 1 degree Fahrenheit, you check for causes. Probe placement, sweat, movement, and then you repeat a third time, okay? If that third reading confirms the second one, say it's 102.6, you now have a verifiable data point. You document the highest consistent reading, so the 102.6, and you can make a small note that the initial reading was verified and found to be transient. This whole process proves you didn't just react, you validated. An auditor sees a nurse who follows protocol.
That's a massive difference. Now let's talk about cadence, the pacing of these checks. When an investigator is looking at a timeline, they're looking for a consistent pattern, right? What does it imply if they just see random checks here and there?
It implies a lack of vigilance. It implies you are being reactive, not proactive. Your charting cadence has to be consistent, and it needs to scale with the patient's condition.
So if the child is stable,
Stable, no fever, maybe every 4 hours while they're awake is fine. But the second that patient becomes febrile, or if you see that trend starting to rise, your cadence has to increase immediately. Every 2 or 3 hours. The real critical failure here is missing that reassessment after you've given medication.
after an antipyretic.
Yes. After you give that dose, you must explicitly schedule and then chart a reassessment check, usually within 60 to 120 minutes. You can't just log the dose and walk away.
And if you miss that reassessment, that's a huge liability gap because you haven't proven your intervention was safe or effective.
That's it. That's where the liability comes from. It stems from vague charting language, from relying on these isolated snapshots. A note that just says temp 102.8, acetaminophen given. That's a transactional note. It tells me what you did, but not what you saw or what you thought. The chart has to show the shape of the temperature trend over time.
The trend documentation, what exactly are investigators looking for in that shape?
They're looking for patterns. Are the peaks getting higher each day?
Yeah.
Is there a high plateau that just won't break? Or are you seeing that sawtooth pattern you want to see, the spikes followed by affected drops? But the highest risk pattern to mischarting accurately is what we call the blunted response.
Okay, define blunted response in real-world terms.
A blunted response is when you give a full therapeutic dose, but the temperature drops less than you'd expect, so less than about 1 to 1.5 degrees. Or maybe even more worrying, the fever rebounds way too quickly.
So it spikes back up in what, 3 hours?
Right, when the dose interval should be 4 to 6 hours, that has to be documented. For example, you give a dose at 1 p.m. for a temp of 103.5. At 2 p.m., it's only down to 103.0. That tiny drop is a signal. It could mean a stronger infection, it could be a sign of sepsis, or maybe the child is just resistant to that particular medication.
And if the nurse doesn't document that minimal drop and doesn't escalate or notify the provider, they've basically failed to act on a critical sign of deterioration.
It's a huge liability gap. It is. Your charting has to show that you're thinking critically. You should write something like, blunted response noted, temp only down 0.5 degrees at 60 minutes post-dose, increased monitoring to Q2H, and notified Dr. X of limited efficacy, continuing to monitor for lethargy. That note proves you were vigilant. You were proactive.
I really like this last piece about synthesis, the need for concise summaries. When you are just buried in flow sheets, how do you pull back and prove you are actually thinking, not just, collecting data?
Synthesis is that final layer of professional accountability, and it doesn't have to be long. The source material recommends just a quick trend summary every day, maybe 2 to 4 lines. That's it.
What goes in it?
You synthesize the most important clinical markers from the last 24 hours. So the peak temperature, the observed response to medication, was it effective or blunted? And the status of the most critical co-symptoms, something like minimal lethargy noted 1400 to 1600, otherwise interactive and hydrated. This simple practice, it transforms you from a data collector into a clinical analyst. It proves you were actually using the information to plan the next steps.
That's a really solid foundation for tracking the illness. Now let's shift to core teaching segment 2. Medication documentation in pediatric fever cases. This is where, precision is everything. Tiny math errors can have huge consequences. How do we document to prove we prevented an error before it even happened?
This whole section is about getting rid of uncertainty through verification. And like we said before, the 2 biggest error sources are stale weights and different concentrations. So your documentation has to nail down 2 facts right from the start.
Which are?
1, the dose is linked directly to the current recorded weight in kilograms. And 2, you have personally verified the specific product concentration you are holding in your hand.
Okay, let's stick with the weight issue for a second. If a baby was weighed 2 weeks ago and they look totally fine, why is it so critical to reweigh them?
Because the margins are just so small, and rapid growth is the norm. For an infant under a year old, a weight that's more than a month old is generally considered stale. It's clinically unsafe for critical dosing.
And for an older child?
Maybe 3 months is the limit. But the point is, you have to chart the date and time the weight was taken, and then clearly link your dose calculation to that weight in kilograms. If you absolutely can't get a new weight, you must document why, and that the provider signed off on accepting that risk.
And the concentration check, can you walk us through a specific risk example there?
Absolutely. So let's say you're giving acetaminophen. The standard concentration you see in a U.S. hospital is usually 160 milligrams per 5 ml. That's 32 milligrams per ml. Now, imagine you're in a home and you pick up a bottle of old infant drops. The concentration on that bottle is 80 milligrams, 0.8 ml.
That's a lot more concentrate.
It's 100 milligrams per ml. It's designed for tiny volumes. So if you mistakenly assume the standard concentration and draw up 5 milligrams of those infant drops, you're not giving 160 milligrams, you're giving 500 milligrams. That's a massive overdose risk.
So the note has to state the concentration.
Explicitly, your documentation must say, acetaminophen 160 mg 5-LO, dose calculated for 15 kilograms child equal 150 milligrams, which is 4.7 LL. That little 160 mg 5-LO part is your proof. It's your evidence that you looked at the label.
Let's talk about guardrails. It's not just about one dose, right? It's about how they can stack up over a few days of being sick. How do you document to prevent that cumulative toxicity?
The chart has to show that you're adhering to all three guardrails. First is the maximum single dose. For acetaminophen, that's 10 to 15 milligrams. For ibuprofen, 5 to 10. Second, the minimum interval, 4 to 6 hours for acetaminophen, 6 to 8 for ibuprofen.
And the third?
The third is the big one for a multi-day illness, the maximum daily dose. For acetaminophen, the general limit is 75 milligrams per day, and you never exceed the adult max of 4 grams. Your documentation has to show a running tally of the total amount given in the last 24 hours.
What does that look like in a flow sheet? Do I have to be constantly recalculating?
This should be visual. A good flow sheet will have a column that says total acetaminophen last 24 hours. You give 200 milligrams at noon, the tally starts. You give another 200 at 4 p.m., the tally is now 4 wrong. If by next morning that child is getting close to 70 kilograms, you have to document that you've checked the remaining daily dose and you flagged that risk for the next shift. That proactive tally is your defense against a cumulative toxicity claim.
Which brings us to the actual routine, the physical process. The 3 checks, 2 verifies, 1 document routine. How does this turn the 5 rights into a completely airtight system?
It's a structure for your physical actions and your critical thinking. The 3 checks are physical. You check the label when you take the bottle out. You check again as you're drawing up the dose. And you do 1 final check right before you give it to the patient.
The verification part seems like the real key here, the thing that separates rushed practice from safe practice.
It's everything. The 2 verifies means, first, you verify your calculated dose against a documented patient-specific dosing card or a reference sheet. You should have that verified number written down somewhere. Second, and this is the crucial safeguard, if it's a high-risk dose or a new medication, you get a secondary verification.
A second nurse. But what if you're working alone, like in home health?
That's a great question. If a second nurse isn't available, your documented self-verification is your defense. You read the entire calculation aloud to yourself, the weight, the concentration, the final volume. And then you note, self-verified calculation based on 15.2 kilogram weight and 32 milligml concentration. Dose, 4.75 ml confirmed. That entry shows you followed a verifiable mental protocol. It proves you paused and thought it through.
Okay, let's talk about the gaps. The things that make an auditor immediately suspicious that monitoring was incomplete.
The single biggest gap is a missing response note. We touched on this, but let's put it in a legal framework. This is the idea of the 5 rights plus 2. The plus 2 are right reason and critically right response monitoring. If you chart a dose given at 10 a.m., and then there's just silence in the chart, no temp, no comfort level, no alertness assessment between 11 and noon, an auditor concludes you failed to monitor the therapeutic effect.
So the unsafe phrasing is just dose given 10:00 a.m.
That's a passive transactional note. It's unsafe. Safe phrasing captures the outcome. It proves you observed and monitored the intervention. It needs a physiological marker and the patient's reaction. Something like Tylenol given 10:00 a.m., reassessed 11:00 a.m., temperature down 1.8 degrees, child visibly resting comfortably, lethargy improving, taking sips of fluid. That level of detail, it validates everything.
Before we move on, what about hidden duplicates? Especially with over-the-counter cold medicines. How does a nurse prove they prevented that kind of accidental overdose?
This happens all the time. A family is giving a multi-symptom cold product that has acetaminophen in it, and the nurse is also giving ordered acetaminophen. The nurse has to document checking the labels of all products being given ordered or OTC, and then confirm that the total daily intake doesn't break the guardrail for any single ingredient. Your note should say something like, verified patient receives no other products containing acetaminophen, total daily dose guardrail confirmed. That shows you were actively looking for that risk.
All right, let's move to core teaching segment 3, which is all about workflow reality. This is where the emotional side of nursing can really complicate documentation. How do we stay objective and protect ourselves when we're dealing with, say, a parent who is refusing medication?
The second emotions get high, your documentation has to become, I'd say, ruthlessly objective. The chart is a record of facts and actions. It's not a diary for your frustrations. This is especially true with refusal. If a parent refuses a dose, your chart needs to record 4 things, objectively.
What are they?
The exact refusal time, the reason they gave, and use their own words if you can, the specific dose that was withheld, and the consultation or education you provided about the risks of that refusal.
Okay, let's run a scenario. The doctor orders ibuprofen. The parent says, "No way. I don't trust ibuprofen. My mother said it's bad for kidneys." How do I chart that without it sounding like I'm escalating things in my notes?
You chart the factual sequence. 16.00. Ibuprofen 5 millinals held. Parents stated, "I don't trust ibuprofen. I think it's bad for his kidneys." Provided education on mechanism of action and risks of sustained high fever. Parent verbally affirmed understanding of risks, but maintained refusal. Notified provider. That's it. You've documented the refusal, their rationale, and that you did your duty to educate. That note protects you completely.
What about that really tricky situation where the child vomits the medicine, the clock is ticking, the family is stressed?
You have to document the exact time of the vomit or refusal. And there's a specific protocol here to prevent accidental double dosing. If the dose is vomited within about 15 minutes, you consult the protocol. You don't just automatically redose.
Right.
You document the action you took and why. If the dose was likely absorbed, say they vomited 30 minutes later, it's generally not repeated.
Right.
You have to prove you paused, you consulted the safety rules, and you made a rational, protocol-driven decision, not just an emotional one in a stressful moment.
The Playbook also talks about something called the parental concern override, which I think is fascinating. We've all been there. The parent has a gut feeling that something is wrong, even when the numbers look okay. How do we document that subjective cue?
Acknowledging that persistent subjective concern from a caregiver is incredibly protective. Sometimes the vitals look great, temp is low, respiratory rate is fine, but the parent is at the bedside saying, "He's just not right, he's way too quiet." You have to document that.
And then you act on it.
Yes, and you document your rationale for acting on it. Instead of charting, objective data stable, parent anxious, which is not protective at all.
So what would you chart instead?
You would chart, parent expressed persistent concern of the child's decreased responsiveness since 1420. Objective data stable. Due to caregiver subjective assessment, monitoring frequency increased from Q4H to Q2H for the next 8 hours. Provider notified of subjective concern. That shows you performed a holistic assessment. It proves you took that subjective risk seriously as a real clinical variable.
Let's pivot to workflow. Nurses can spend half their shift charting. So how do we structure this efficiently to avoid overcharting, which can just bury the important details? Where does the raw data go, and where does the critical thinking go?
Efficiency comes from a clean separation between your flow sheets and your narrative notes. Think of the flow sheets as the place for high-volume, standardized data, time, temp, site, dose in ml and MBA, IO totals. And simple checkboxes for red flags like lethargy, yes, no. Flow sheets are fast, they're easy to audit, and the data is instantly comparable.
So the flow sheet is for the numbers, the metrics. The narrative is for the story.
Precisely. Your narrative notes are for complex context, for your assessment summaries, for any deviations from the plan, and for communication. This is where your 1-minute SBAR summary goes. It's also where you document instructions you got from a clinician, including that crucial teach-back confirmation.
Like, I repeated the order back to the doctor.
It's exactly. Confirmed dose change to 5 millimL and new Q6H interval with Dr. Y, and of course the rationale for any major deviation. The key is to keep narrative short, structured, and focused on context.
And finally, coordination across shifts. How do we prevent that #1 medication error between shifts, which is double dosing?
This comes down to standardized handoffs and clear visual indicators. The system has to have a mechanism. Maybe it's a dose-administered check on a whiteboard. Maybe it's a super concise handoff note that eliminates any possible confusion about whether a critical dose was given. The risk of duplication is highest during shift change or a meal break. If you've given a dose but haven't logged it yet, you're putting your colleague at extreme risk.
That brings us to our final core segment, the audit and legal lens. Let's put on the magnifying glass. An adverse event happens, a child gets worse, has a bad reaction, or there's an overdose. How are these charts reviewed, and what's the key legal vulnerability for the nurse?
When an investigation starts, Whether it's the state board, hospital risk management, or a law firm, they are not just looking for data. They're looking for clear, consistent evidence of monitoring, of interpretation, and of proactive risk management. They're assessing if your charting actually supported your decisions.
So they're rebuilding the timeline to see if your documentation matches your actions or your lack of action.
Exactly right. They perform a really sophisticated trend analysis. They're looking at the temperature curve, the hydration status, the response to meds, and they're asking, did this data logically lead to the nurse's next decision? Whether that was to escalate, to notify, or to just keep monitoring. If the patient went downhill fast, but the chart shows inconsistent readings, or you fail to note that blunted response we talked about, your defense is, well, it's profoundly weakened.
Because the data suggests the deterioration should have been caught earlier.
It suggests it should have been spotted, yes.
Let's go back to that medication vulnerability. We talked about missing response notes, but what is the specific legal implication of not charting that 60 to 120-minute reassessment after giving a dose?
Legally, the absence of that required reassessment note is interpreted as a failure of monitoring. It's a breach of the standard of care. You might have gotten the right dose and the right time, but if you don't chart that follow-up, you fail to confirm the therapeutic effect, and most importantly, the patient's safety afterward. Legally, it just implies a breakdown in your vigilance. You can't prove you were actively ensuring the intervention was safe and effective.
That distinction is so critical. It's not about the paperwork. It's about proving the act of professional monitoring took place. Okay, I want to circle back to a phrase that nurses use all the time, but the Playbook calls it non-protective language, charting given as ordered. Why is that not enough to protect a nurse legally?
Because your professional duty of care requires more than just, simple obedience. The nurse is the final mandated layer of clinical verification. You are accountable for validating that order against the patient's current clinical status, their current weight, and the medication's concentration. The doctor orders, the nurse validates. If the order is flawed, the nurse who gives it takes on that responsibility.
Give us a scenario where that fails the nurse.
Okay, imagine a doctor orders 200 milligrams of ibuprofen based on weight from 6 months ago. The nurse sees the order, checks the chart, and notices the weight is stale. For the child's current weight, the dose is actually too high, say. It works out to 12 milligrams instead of the max 10. If the nurse just gives the 200 milligrams and charts given as ordered, and the child has a complication, both the doctor and the nurse are liable. But the nurse is specifically culpable for failing that duty of validation.
So what does protective documentation look like in that case? How do you prove you were the critical thinker?
Protective documentation shows proof of the verification step. In that scenario, the nurse would document. Order for 200 milligrams ibuprofen received. Verified current weight is 18 kilograms. Max dose for 18 kilograms is 180 milligrams. Provider notified of discrepancy. New verbal order received for 180 milligrams. Calculation validated. 180 milligrams, 10 milligrams equals 18 kilograms. Administered 9 milligrams, 180 milligrams. That verification trail is your entire defense. It proves you applied critical thinking and protected the patient, even when the original order had a flaw.
That's a powerful reframing. It's not compliance, it's defense. So let's move into our closing coaching segment. After all these standards and details, what is the core message for that busy nurse who's trying to do all this under incredible pressure?
The core message is this. You have to reframe documentation as your professional voice. It is not just a list of clerical tasks. It is your most important safety system. When you prioritize standardization, when you log trends in real time, and when you explicitly verify every calculation, you are building your license protection as you go. You are creating evidence that proves your competence and your vigilance to anyone who looks at that chart.
And what about just managing the cognitive load of it all? We've thrown out a lot of numbers and procedures. How does a nurse reduce that mental strain during a really tough shift?
By using structured tools. The Playbook really emphasizes things like SBR worksheets, patient-specific dosing cards, and checklists for a reason. They shorten your decision time, and they eliminate mental math when you're tired. If you have a laminated dosing card taped to the bedside that's based on the patient's current verified weight, and it just says max Tylenol dose, 4.8 ml, you don't have to pull out a calculator and risk an error in a critical moment.
The tools remove the friction.
They remove the friction, and they let you dedicate your full cognitive attention to the patient, not to the math.
Okay, final thoughts from you. Any last encouragement for our listeners?
I'd say the transformation to this nurse standard level of charting is complete when you learn to trust the system more than you trust your own memory. You're setting up a process that will work even when you are exhausted or distracted. So I'll leave you with this question to ask yourself. When you look at your chart, your professional history, Does it tell a clear, concise, verified story that would satisfy a complete stranger, a legal investigator? If your log speaks for you, if it details your consistent checks, your trend analysis, your verification steps, then you are not only protected, you're providing the absolute safest, highest standard of pediatric care possible.
You are listening to the Nurse Documentation Podcast, brought to you by Nightingale.
Nurse documentation. Protect the care you gave. Protect the license you hold. With every note